Today we're going to talk about blockages of central lines. Right now you see here we have all the necessary tools that we'll need to perform a procedure of a thrombotic occlusion management. This is a Groshong pick, which is our old style. This will work the same on all picks, although the new ones, the Navalist and the Bard Solo, are a little different. Their valve is at the business end here on the outside, and they do take a little more force because they can take about 300 psi because we use them to inject dye for DI purposes. So first things first, as any good assessment would have you do, you will need to have to see what is the actual problem. Sometimes it's a matter of just that the pick is a little sluggish, or it may be actually completely blocked. So you need to at least check out the force which you have to use. Now, on the Groshongs, you can't be as forceful as you can be with the new Navalist and the new Solos because of that whole DI thing. So it's a clean procedure. You don't need a sterile tray, but you will need to scrub your connector. I'm using the larger of the swabs available within the hospital. You may not have them on your unit, but if you do, they're preferred because of the chlorhexidine in them. You're going to swab your connector here going all the way around the threads in the end. That's why I prefer these, for 30 seconds. If you want to, you can sing Happy Birthday to Me twice, and that will be sufficient time. Prime your syringe, making sure that you don't slip around like I did. And the very first thing you might want to do is just try pushing. And again, you have to look at the kind of catheter you're using. So if you find that you don't get any forward advancement like this, where you're getting resistance, you don't want to force them. You can be a little more, a little more aggressive with the Solos and the Navalist, though. If you can't get anything in, and you can't draw anything out. Now, to draw, I often say you need to waste probably half of your syringe to give you some play. And when you connect, then you can see if you have any jam in it. Again, you don't want to force it. If you cannot aspirate any blood, you don't see blood coming up the catheter. And if you can't flush, you likely will not aspirate. Anything that you can flush and it seems very tight or very resistant and you cannot get blood is considered a partial. So flush but not able to bring blood or aspirate back is a partial. A partial is treated differently than a total. So I'll speak to the partial first, and then I'll talk about the total after that. So I'm just going to put my syringe aside. So we've now determined that we have a blocked lumen. So for the sake of argument, we're going to assume that we can flush this, but we cannot aspirate it. You're going to use the same solution for this. You're going to need Alteplase or Cathflo. The dosage is clearly marked, and it's a standard dose. It only comes in one type of solution. It's the only one approved for use, and it only comes in the dose of 2 milligrams. Don't confuse this with the one we use for MIs. It's a much higher dose. This is the one you will be asking for. And you will need sterile water for injection, and both of those are going to be for reconstituting the Cathflo. Now, when the Cathflo comes to you, obviously it's going to have a top on it. It's going to have a little purple top. You're going to snap your tops off. You're going to clean your bottles, of course, and scrubbing the tops on them and making sure that they dry. While they're drying, you're then going to get yourself an empty 10 ml syringe. Pretty standard issue. Right now, on all central lines, you can't use anything smaller than a 10 ml syringe for flushing. In some cases, if you are comfortable, you could use a smaller syringe, a 5 or a 3, to aspirate. That is, if you can actually use more suction to try and clear the blockage, but not for flushing. You're going to take your syringe, you're going to find yourself a blunt cannula, which I do believe was here a moment ago, and any old blunt cannula, and you can then, here it is, draw up your solution of sterile water, and you're going to use 2.2 mils, no more, no less. After you've swabbed, you're going to draw up 2.2 mils of sterile water, preservative free, of course, and then you're going to go through the cap of your Cathflo, and you're going to direct the stream against the side of the bottle. Now, the Cathflo, when you get it, looks a lot like a little bit of powder, and that powder is a kind of a disc at the bottom. You only want to gently agitate. In other words, you're not making a martini, so you're just like tea with the queen. You're going to turn your hand and the bottle very gently, and very soon you'll see that it'll become a clear fluid that will have absolutely no bubbles, no froth, and it will not have any chunks in it. When you're done reconstituting, you're going to swab, access the bottle again with the same blunt cannula, tip up the bottle. You'll also notice you're not going to get, almost always not going to get the whole 2.2 mils, but you're going to get pretty near that. You're going to draw up your 2.2 mils back into your syringe. Put your bottle aside. Just tap your syringe a bit. You can prime your needle if you want. You're not going to be using the needle. It's really only as a means to getting the stuff out of the bottle. Then you're going to return to your patient. Pick the lumen that is partially occluded. Now, I'm going to remind you again, you can flush fluid through it. It may be even stiff or sluggish, but you can put saline in. What you're not getting is blood out. This is the simplest of the two. You're going to swab again for 30 seconds, making sure you get around the threads and over the end. In other words, you don't want to give this a lick and a promise. You want to take off the end of your blunt cannula, and if you're real talented, you can do it with one hand. You're going to lure lock on your alteplase, and you're going to slowly and just gently instill 1 mil of fluid. Now, of course, this one is potentially, in this scenario, is blocked, but you're going to instill about 1 mil. That is because the luminal volume of a Groshong pick is about 0.5 cc's, so 1 mil is more than enough. The tiny bit that does get into the systemic circulation would be basically neutralized or taken up in the liver within a very short time, and it poses no danger to the patient. But you want to avoid giving them excessive amounts of anything. Once you've done that, you can let it sit aside. If you're going to be leaving the shift, and hopefully you're not doing this too early or too late in the day, what you would do is then take a catheter, and you would put on the alteplase sticker. Now, if you go on the website, you can actually get these off of the website, and they're purple, just like the alteplase, and they're actually marked with alteplase on it. What this is a fair warning to anybody coming along. Please don't use it because there's alteplase in the line. Whether you're using a partial or a total occlusion protocol, this is still the same. You want to label your catheter. So, if you follow the algorithm online that is on the policy and procedure, you would let this sit for about 30 minutes. You would go back with an empty 10 mil syringe, and you would attempt to aspirate from the end of the syringe. So we're just going to go back and pretend 30 minutes has passed. And we're going to go back and swab again. Same deal, 30 seconds as per policy. Once you're done that, you're going to take an empty syringe. In this case, I'm obviously pretending that this is an empty syringe. Lure it on, and you're going to aspirate or attempt to pull back. If at that time you get blood coming up, you're going to aspirate about 1 mil or so. You don't have to go crazy. Then you're going to take 2 10 mil syringes from the sterile packaging, and you're going to then follow with a 20 mil flush after you've aspirated the residual amount of that alteplase and some blood. That's a partial occlusion policy. Now, at the time you go to aspirate, if you find that you can't get anything back, and you've lured on and you pull and you're not getting anything, you're just going to return the catheter to its former state, just putting back what you would pull back, and you're going to wait another hour. Come back and try again. If at that time you do not get a result, you will treat the line again as you would and start from the beginning with about 1 mil of alteplase. Now, generally it's been my observation, the longer you leave it to sit, the better it works. Even in a partial occlusion, an hour is not a bad time. That's a pretty fast time to go by when you're busy girl. So an hour is not going to cause any harm. You can go as early as a half an hour if it's something like the patient's being discharged and you need to be in a more timely sort of success of this. Now, if you have a fully occluded catheter, all of the steps that I've talked about are pretty near the same, but what you want to do in this case is when you get your alteplase, you're going to use a single syringe method. So once you've reconstituted your alteplase, you've swabbed your catheter really well, and you have your syringe full of alteplase, you're going to place it in a dependent position. That means it's going to be alteplase down. The very first thing you're going to do is pull back on your syringe. If you don't get any blood return and you can't flush, that is called a total occlusion. Most people say, how can you get stuff into an empty line? If you remember, when we have blocked NG tubes, we use a codezyme, and we use a very similar kind of method. So what you're going to do is pull back on your syringe real good, and you're going to have nice strong hands, and you're going to come back to about 8 on your syringe. And you're going to hold that, and hopefully what you're doing is trying to pull as much fluid in the line up to where the interface of the clot is, removing everything and suctioning the line together so that you're creating a negative or vacuum space. You're going to hold it there for a couple of seconds, and then you're going to gently let the catheter go back until the syringe no longer has any pull on it, and you're going to wash, rinse, and repeat until either your fingers fall off or that you have at least moved some of the contents into that empty space. What you've done is removed any fluid in the line up to the clot, and you then replace it with fluid back in the line. The analogy that I've seen, and I'm going to continue to do this while I explain the best explanation I've ever heard about this from an expert. Picture your clot in your line like a bowl of red jello. And so when you make jello, the clot or the jello is stuck to the side of the bowl. So that's your clot in your line. What you're doing when you're creating a vacuum like this is that you are pulling on the jello, making minute cracks in the surface of the jello. Then you're going to picture it to be a quart of cream, and you're going to pour it on top of the jello. And any cracks that you've made in the jello, the cream is going to fill in those minute cracks. That's alteplase. So when you vacuum, you create micro fissures, hopefully, in that clot. When you release and let it go back down the line, it's like pouring cream down over that red jello. You're going to keep doing that until you make more cracks, more fissures, and fill it with more cream. The longer you do that, the more you're going to deliver the product into the line. So again, suction back, pull up to 8, hold for a second, let it go down, controlling it, and repeat, repeat, repeat until you've probably spent a good 5 or 6 minutes, maybe 10. At the end of it, you should have less alteplase in the line, which would mean that whatever the 2.2 mils was in, you should then only have a partial dose. When you've got part of that in there, the website for alteplase says that you can then tape that to the patient's arm and leave it and follow the algorithm 30 minutes. If nothing, pull back, so in 30 minutes you'd come back. In most cases, I deattach it because I'm not too sure the patient wouldn't play with it, or that we don't tend to follow that, but it is something that the website for alteplase recommends. In this case, I would take a sterile cap, I would label the syringe, I would put it in a bag, and I would put it in the fridge to save it. Because this stuff is about $100 a dose, you probably don't want to throw this away and use 2 vials to treat a line if you have to. It doesn't specifically say that in the policy. That is just something that if you make sure that your syringe is kept sterile and kept separate, there should be no issues with that. Now, again, I'll remind you that the website does recommend you leave it attached to the end and label it alteplase instilled. You're going to do the same thing with this, and you're going to leave it for 30 minutes. You're going to then come back with your, again, with your alteplase. Sometimes you can use the remainder, and that's why I keep it in the fridge. After reconstitution, this is good for 8 hours, and after that, it will not be usable anymore. It is refrigerated when it comes to you. It should be refrigerated when it's not in use. But again, the website does recommend just leaving it, labeling it, and then coming back and doing the same thing again. So you're going to pull up to 8, hold, and bring that syringe down gently. So what you don't want to do is pull it up and do that. Okay? That's a no-no. All right, so again, back and forth up to 8, release slowly. Now, usually by the second time that you do this, you're going to see usually some tiny bubbles of blood coming up the line. So what's happening is that the cream that we've poured onto the cracks of the jello, that analogy I used earlier, is now loosening up those fibrin bits that form clots and break them up, so eventually you're able to vacuum that clot right out of the line. It doesn't always work first go. I will tell you anecdotally that if you leave it in overnight with a sticker on it, usually by the next morning you have success. That isn't always where we are clinically. Sometimes we need to have that line because we're infusing. Now, even though the first line is clogged, if this one is still running, they are separate. They run parallel, so you can use the other line. What the policy says is that a line that has got a thrombolytic embolus or a small clot in it is going to put the patient at a risk for infection, so you want to clear that up as soon as possible. Again, if you leave it longer than 30 minutes, you have better success. And you can use that one dose for the second treatment. So when you get to the 120 minutes, if you haven't cleared it up, you want to pull back with an empty syringe, anything that's in the line, vacuum it out, and instill the other part that you've been saving in the fridge, if you haven't already used it. Don't worry if you suck blood up in the line. Remember, anything that's in contact with the alteplase is going to break up. It's not going to clag. It's just going to look bloody, but it's still going to be an effective thing. And usually the success, I've maybe had one in all the years I've done this, not do it, and when we pulled it out there was a fairly extensive clot. If you get them early when they're sluggish, you only need to do a partial treatment, and that's always my best recommendation and option to you. Thank you very much.